First, the concept of focal therapy. What does it mean? Well, we'll get into that in great detail. Index cancer is a guidepost for how we can tailor our treatment to really address the individual's need. Active surveillance, we'll emphasize that. Mapping biopsy and incidental cancer. This particular cancer is not important. This is a web address of the 3rd International Symposium on Focal Therapy for Prostate and Renal Cancer. This meeting occurred in Washington in February of this year, and I was fortunate enough not only to be at the meeting, but to present some of the work we have done here. There was a tremendous amount of information exchanged here that I think is going to change the face of how prostate cancer is treated very soon for the future. This ice, as you'll see in a moment, is lethal ice, meaning that it creates an instant change in the cell composition, and essentially at the point where the ice has a temperature of minus 40 degrees or lower, the cells are destroyed. Now here are cryoprobes in position through a grid, and this is how the cryoenergy is then directed and delivered. We put together a study that consisted of 82 patients that we followed now for 5 years. And we monitored these patients after their diagnosis with biopsy and PSA. In other words, we made the diagnosis of prostate cancer, and this was a global treatment. And if we found men who had positive biopsies, and there weren't many, but some did occur, we retreated them with the same technology. Of this group, 85%, as best we can tell to this date with follow-up, have done very well. 15% did have positive biopsy. We saw our failures with biopsy with very low PSAs. There were 11 men who were retreated. 10 of them now have negative biopsies. What we learned from this was early biopsy following treatment gave us an inside track on what we could do to deal with potential bad outcomes and make them good outcomes. There are some modifications, and those modifications have evolved now, and I want to talk to you more specifically about them. So the real question is, now this is a prostate that was surgically removed. Is it all, none, or is there something in between that we might choose to do about this disease that would be successful and produce cure? At the time of diagnosis, thinking about this prostate now, is the volume of cancer in the prostate important? Well, I submit to you that it is. The breast is a metaphor, in my mind, for progression of treatment for cancer that's successful. It wasn't very many years ago that when the subject of breast cancer was brought up, it was almost synonymous with radical mastectomy. When's the last time you heard that term? Been a while, hasn't it? Why? It's been replaced by another approach, lumpectomy, isn't it? So lumpectomy means we left the organ in place, we found the bad spot in the apple, and we took care of the bad spot. We found the bad spot in the breast, we took care of the bad spot. This is the doorstep to focal therapy for prostate cancer. We want to understand where the problem is in the prostate, and there's a very good reason for that. So what we really want to know is, can we take care of a portion of the prostate and leave the rest of the prostate alone? And this is the ultrasound probe in the rectum, and this is a grid that has a sister image. The image that's produced by the ultrasound probe shows us the prostate. We can take biopsy needles and put it in very specific parts of the prostate. Now, making the assumption that there's a cancer in the prostate, the amount of cancer that we find on a given biopsy specimen can tell us, for instance, if this came from a portion of the prostate that had a large deposit of cancer or a small deposit of cancer, because the length of the pathology on the biopsy specimen correlates with the size of the problem. We'll call that a lesion that we biopsied. With that, we can make up a map of the prostate, and we can say that we have trouble in certain areas, and not only do we have trouble in certain areas, we can tell what the grade of the tumor is, and we can estimate the volume of the tumor. There is a probability that some of the cancers we find in the prostate don't need to be treated. Remember, we were talking a few moments ago about an insignificant prostate cancer. Well, if PSA is so sensitive that it tells us that, it also will tell us where the prostates are that have the problems. So now it's our job to understand what's significant and what isn't. Now remember the picture of the prostate in the jar, all or none? Well, if we take out a lot of prostates that have insignificant prostate cancer, there's some problems associated with that. Occasionally people will have leakage, other problems that relate to the surgical event itself, and of course it can disrupt sexual function because the prostate is part of the reproductive tract, and this is where the reproductive tract and the urinary tract come together. So could there be something in the middle? Well, it's focal therapy. Focal therapy, think about it as the bad spot in the apple is the real trouble, and if we can identify that and treat that area, we have a very good chance of altering the disease process so it's not going to harm the patient. Do focal therapy and active surveillance compete? Probably do. Can focal therapy be used in a way that can be definitive and solve a patient's problem? We think it can. Index cancer. You heard that topic before. Here's a prostate, and it has more than one cancer in it. It appears that if the volume of a prostate cancer lesion is bigger than 0.5 cc's, it has a very high probability of being the troublemaker. And if it's less than 0.2 of a cc, it has a very high probability of being not an aggressive tumor, and it very likely will do nothing but sit there and not evolve into a big problem. So this meets the criteria of the index lesion, and usually the grading system, which tells us what the cells look like under the microscope, is higher, of 7 or higher, and the less significant findings a Gleason grade of 6 or lower. Is the index lesion responsible for progression of disease? We think it is. If the index lesion had a high Gleason score and a volume of significance, the probability of a good outcome in that case was reduced. Not eliminated, but statistically less. And interestingly enough, grade small volume tumors in total could add up to more volume independently, putting them together, than the index lesion. But the index lesion still was the driving force as to what happened in this case of prostate cancer.